laboratories and hospitals for about 10 years, and then for about 10 years was the clinical director of a large specialty practice, a pulmonary practice with 15 pulmonologists. So I'm pretty familiar with the clinical side, certainly, and the special needs of specialists. I've been an implementation project manager for practice management and EHRs for a number of large EHR vendors, and I've done a lot of implementations both in the U.S. and Asia. For the last 4 or 5 years, I've consulted directly with numerous EHR and other HIT vendors in the area of interface specification and certifications and meaningful use. I've worked with over 75 vendors, probably over 100 now. And certainly my work with these vendors has escalated since the R legislation has passed. And in particular, I'm looking forward to talking tonight about the role of meaningful use with specialists, because many of my vendor clients that I'm helping get their applications certified for meaningful use are in targeted specialty markets. And so it has been a real challenge for those vendors, and I really salute them, their capability to still maintain that focus for their specialty niche that they're in, while still trying to encompass the broader range of meaningful use as it's been handed down to us to make those incentives possible moving forward. Just want to cover a little bit of history about the ARA HITECH Act. It truly did come out of the blue. Tom Daschle, who was almost the head of HHS a couple of years ago, wrote a book on healthcare delivery in America. And one thing that Mr. Daschle said was that at some point there would be a large incentive stimulus budget passed for HIT adoption, electronic health records for hospitals and eligible providers, but that the only way it would pass would be if it was inserted into a massive stimulus bill, probably during a crisis. 2 years after his book was published, that actually became true. We all remember the global economic upheaval of the fall of 2008 and the 70 billion plus incentive package, the stimulus bill that was signed into law. Included in that package was what's known as the HITECH Act, which was the funding to really increase the adoption of EHRs by physicians and hospitals. Truly, healthcare delivery is the last major industry to be computerized. I guess the banks did it in the 60s. And the percentage of implementation, certainly among specialists and even general practitioners, somewhere in the range of 20 to 25%, and really had stagnated. But this massive influx of money for training and for direct incentives to providers and hospitals is really driving those implementation and adoption rates. The final rule, there are actually several final rules. The HITECH Act itself provides the basis for the incentive payments to the eligible hospitals and providers. And I'm not sure who came up with the term meaningful users of certified EHR technology, but whoever coined that phrase, that has been codified in the regulations by Office of National Coordinator and CMS. And that's the one phrase that everybody knows. We have to be meaningful users. The regulations, the final rules for these programs became effective in September of last year. One of the first questions that always comes up when I talk to providers is which program to choose. There are two programs. There's the Medicare incentive for EHRs, and there's the Medicaid incentive for EHR meaningful use. And you can't use both. Hospitals, interestingly enough, can qualify for both Medicaid and Medicare incentives, but for eligible providers, it's either one program or the other. And so we're going to examine the differences between these two programs just a little bit. But since I imagine most specialists and most people who are on the call right now are going to be more focused on the Medicare program, we will spend a little more time on that. Switching programs, interestingly enough, if you choose to be in the Medicare program or choose to be in the Medicaid program, you're allowed to switch one-time programs before 2015. So if you start in Medicare and you have a sufficient threshold of patient percentages that you could claim the Medicaid incentives, then you could switch to Medicaid and vice versa. The standards are actually lower to be a meaningful user in the Medicaid program, and the reimbursement is higher. So all things being equal, it's always best to qualify under a Medicaid program, but many providers are not able to. We'll go into a little more detail about that in just a minute or so. As I said, Medicare versus Medicaid program, some key differences here. Under Medicare, the federal government will implement, and this is an option that's available nationally. The rules for the Medicare EHR incentives are consistent across the board. For Medicaid, this is truly voluntary for states. Most states have already begun their programs earlier this month, but they don't have to. The federal government will actually provide most of the incentives for these Medicaid programs, but Medicaid, since it's a state-run program, the actual definitions of meaningful use can be slightly different than the national standards for Medicare. The way the program works a little bit from state to state can vary somewhere, so a little bit more flexibility on Medicaid. And if what might be a correct answer for a Medicaid question in Texas would be answered differently depending on if we ask that question to the Medicaid organization in Georgia. So a little bit of difference there. Under Medicare, payment reductions actually begin in 2015 for providers that do not demonstrate meaningful use. The incentive program has been established with the incentives being front-end loaded. By that, I mean if you demonstrate meaningful use of certified technology in 2011 or 2012, you will be eligible for the maximum incentives. If you wait to 2013, then it's less incentives as years go by. If you do not become a meaningful user, eventually there will be penalties, and those penalties will increase as far as Medicare reimbursement. So it's a carrot and stick approach. The carrot is bigger in 2011, 2012, front-end loaded. Interestingly enough, under Medicaid, there are no payment reductions, no penalties whatsoever if you are in the Medicaid program and do not become a meaningful user. Under Medicare, and we'll get into a few of the details about this, ability to demonstrate meaningful use in year one and every subsequent year to qualify for the incentives. Not true under Medicaid. Under Medicaid, for the first year, there's no requirement to actually demonstrate meaningful use, only that you adopt, implement, or acquire a qualified EHR, and then meaningful use demonstration is required in every subsequent year to qualify. Back to the Medicare side for just a minute. That first year of qualification, the regulations have, I don't want to say they've been curved, but there certainly has been an attempt by the federal government and the regulations to make entry into this program as easy as possible in a couple of different ways. One is that for the first year that you're a meaningful user, you only have to document that meaningful use of certified technology for 90 consecutive days. Every subsequent year, it's the full year period. So it makes it a little bit easier that to get the full year incentives, if one was eligible in 2011, only 90 days of consecutive use are required. Under Medicare, the maximum incentive is $44,000 over the period of the incentive program. In certain particular areas, there's a 10% bonus on top of that. And as you see under Medicaid, the maximum incentive is actually over $63,000. So we talked about that earlier, higher incentive base there. Common definition of meaningful use for Medicare can vary a little bit from state to state under Medicaid. Last year provider under Medicare may initiate and become a first-year meaningful user is 2014. Last year the register is 2016. And 2015, if you're not in the program, it's when those, they call them payment adjustments, but we know that's going to be reimbursement adjustments. Those are going to be penalties. Under Medicaid, certainly you can wait and initiate as late as 2016 and no penalties at any time whatsoever. We're going to look in just a minute about under Medicare and Medicaid, there is a slightly different definition of what an eligible provider is. As I said earlier, we're going to really focus on the Medicare side here a little bit. Under the Medicare program, definition of an eligible provider is a physician, which include osteopathic physicians, dentists, podiatrists, optometrists, and chiropractors. One thing that is interesting here is you've heard a lot of talk probably, as well as I have, from many providers out there who are in behavioral health. And under the Medicare program for EHR incentives, the only possible behavioral health eligible provider would be a psychiatrist. No option really other than psychiatrists for behavioral health for the Medicare program. Several different ways to get into the Medicare incentive program. There's a Medicare Advantage program. Talk here a little bit about the fee-for-service incentive program, which I believe most of the people on the call are interested in. And in particular, how the incentive amount is calculated. As the slide shows, that the annual limit is equal, maximum annual limit is 75% of Medicare allowed charges for covered professional services furnished during the payment year. For 2011 and 2012, the maximum incentive for most Medicare providers is set at $18,000. And so that $18,000 incentive, which is a maximum, would be based on a $24,000 Medicare billing amount. So theoretically, the maximum incentive that a Medicare provider could get, they would be eligible to the $18,000 as soon as they had been in the program, demonstrated meaningful use of certified technology for 90 consecutive business days, and then as soon as they have reached that $24,000 of Medicare fee-for-service billing, they would be eligible for that maximum $18,000 incentive. And of course, as we say, the calculation is based on claims submitted to Medicare no later than 2 months following the end of the payment year. But for that first year, we don't have to wait for the end of the payment year. It can be based, there are already a number of Medicare providers that I'm aware of who really were meaningful users on January 3rd when the program began. And their Medicare fee-for-service is high enough, so January, February, March, early April, they're going to hit that maximum amount of billing to get the maximum $18,000 incentive. They've been meaningful users for 90 consecutive days, January, February, March. In April, they're going to apply for the incentives, and in May, they're going to get checks for $18,000 per provider. The eligible provider is entitled to this incentive payment for up to 5 years. As we discussed earlier, those payment amounts go down over time. No incentive payments after 2016. Interesting chart here. This is the maximum total amount of the EHR incentives for a Medicare eligible provider. And as I mentioned earlier, that in the health professional shortage area, there could be a 10% bonus on top, but we're not going to take that into account for the numbers we look at here. We can see that if a provider, eligible provider under Medicare, enters the program and meets the requirements in 2011 or 2012, they will get the maximum incentive. if they stay in the program, $44,000. If they wait to enter the program in 2013, there's going to be a $5,000 less potential incentive, and quite a drop-off from 2013 to 2014. So the real goal to maximize incentives, if you're going to enter the program at all, you want to enter it early, is to become a first-year user in either 2011 or 2012. Now, since that 90-day consecutive period of meaningful use in the first year is true for your first year, eligible provider, as long as they are a meaningful user of certified technology, we'll talk the definition of that in a few minutes, by October 1st, 2012, they'd have the 90 days for the end of 2012, they will get maximum incentives. So whether it's this year or sometime next year, there's still plenty of time to make the adjustments necessary, obtain hardware and software if necessary, do a proper gap analysis to see what you need to do for meaningful use and make adjustments to workflow. So no need to rush, no need to rush. There are 3 stages of meaningful use. The goal of the high-tech legislation was to take healthcare delivery in this country from a essentially paper-based system to a computerized system, and that cannot be done in one step. An example I will give is that we hope that in 5 or 6 years from now that there will be very strong, very robust, very vibrant health information exchanges in this country, so that clinical information on a particular patient can be exchanged very easily from a provider to a hospital to maybe from a general practitioner to a specialist for referral. But that can't be done overnight. So that may be our goal in stage 3. But for stage 1, what has to be incorporated in the certified technology as well as the meaningful use of that technology is the very first steps of how to properly secure files, make sure files can be encrypted, make sure the technology in the EHRs can support the ability to tell if a file has been modified, maintain file integrity, things like that. So the way I view it is that stage 3, we want to be running. In stage 2, which we don't fully know the criteria on yet, we want to be walking. And stage 1, which is what we've just entered and will be in for the next 2 years, we want to at least be standing up. So there's 3 different stages. Certified technology. Right now, technology, EHRs and EHR modules are being certified for stage 1 functionality and security and interoperability. By the end of this year, the standards will be worked out for what will be stage 2 criteria that will be required to be in these EHRs and EHR modules. And there'll be a year of testing, and by 2013, those stage 2 products will be available. And then stage 3, there'll be another level of certifications that will be required to make sure that foundation is in place inside the EHRs and EHR modules that we use. So 3 stages for the certified technology to evolve, as well as an increasing requirement for hospitals and eligible providers to be meaningful users. So what's required for us for stage 1 is to be a meaningful use. We'll get into the details of it in a minute. For stage 2, it's going to be a higher bar, more functionality, and higher percentage thresholds of what we have to actually accomplish. So for eligible provider, a internist, a dentist, a urologist, fill in the blank, any type of eligible provider in the Medicare system that I want to focus on, there are actually 25 different meaningful use objectives for stage 1. There are 15 stage 1 core objectives. These are requirements that CMS says a provider should do, has to do. And then we'll look in just a minute, there are another 10 from what they call the menu set, and the provider is expected to be able to defer 5 of those. So they have to do all 15 of these and then 5 of the other 10 for a total of demonstrating 20 different meaningful use objectives. Well, immediately, as soon as this list came out, a lot of specialists I talked to said, well, there's no way I can do that. I don't write prescriptions, so how am I going to meet the requirement for e-prescribing if that's a core objective? So quite a few of these objectives, both from the core set and the menu set, are outside the scope of what many physicians and especially specialists would do in their practice in healthcare delivery. Thank goodness that the ability to exclude, even from the core set objectives, has been put into the system for stage 1. We'll look at some of the details of those in just a minute. In my conversations with officials both at CMS and the Office of National Coordinator for HIT Adoption, they are focused on a mission of HIT adoption for this country. One thing they're very clear on is that there must be buy-in by the hospitals, by providers, and by the EHR vendor industry itself. That if people don't buy into this program, HIT adoption will not work. So under stage 1, much flexibility has been put into this. Such things as for the first year, as we mentioned, only had to be eligible provider for 90 days. Even though some of these meaningful use objectives are considered core objectives, if they're outside the scope of practice, you can exclude them and not have to do it. So there are quite a few things that have been put in to kind of ease our way into this. If the requirements were too strict, too stringent, too rigid, HIT adoption would really it'd be a much steeper climb for us. I'll kind of run through these quickly here. These are the 15 stage 1 core objectives for meaningful users, eligible providers. Ability to computerize provider order entry. We'll talk details in a minute, but some eligible providers don't order. Some radiologists who may well be an eligible provider don't document patients. Like there are exclusions for those. But CPOE, the ability to e-prescribe, this is not electronic fax, this is actually e-prescribing, sending prescriptions over computer networks. The ability to report clinical quality measures to CMS or to the states in case of Medicaid. The requirement to implement one clinical decision support rule. An example of this would be an EHR. If we had a rule and alert in EHR, that would give us a clinical decision alert when we encountered a patient with a certain diagnosis on a certain medication with a certain lab value and a certain demographic age, that we would get an alert based on that. Or core objective to provide patients with an electronic copy of their health information upon request, to provide clinical summaries for patients for each office visit, to perform drug-to-drug and drug allergy interaction checks in real time, and to record demographics. Also part of those core objectives, requirement to maintain up-to-date problem lists of current and active diagnoses, maintain active medication and medication allergy lists. Interestingly enough, the requirement, active medication allergy list, there's not a requirement that we maintain an allergy list, environmental or food allergies. There's a medication allergy list. I bet in stage 2 or stage 3, that will be a full-blown allergy list, though. The ability to record and chart changes in vital signs, ability to record smoking status for patients 13 years or older. Good question there for specialists. What if you only see patients who are under the age of 8? It's going to be a little hard to do that, and luckily that's an exclusion. The ability to exchange key clinical information among providers of care. Those are those interoperability documents that carry clinical information on a specific patient. and of course, privacy and security, protect that electronic health information. The menu set objectives, as we said, without any exclusions whatsoever, the requirement is to do the 15 core meaningful use objectives and at least 5 of these 10. You defer 5. And for stage 1, have to perform 5. Drug formulary checks, that's checking a preferred drug list or perhaps a patient's insurance to see if a particular medication is covered or what tier it's covered under. The ability to incorporate clinical lab test results as structured data so that it can be searched. Generate a list of patients by conditions, send reminders to patients based on their patient preference, how they want to be communicated, kind of reminders or wellness type communications. Provide patients with timely electronic access to their health information. That could be as simple as, or it could be as complex as having a full-blown patient portal where patients log in, or it could be just as simple as having the ability to send patient information to Microsoft Health Vault, where a patient could log in and get their information. The ability to provide patient-specific educational resources, medication reconciliation, summary of care record for transitions of care, and then the last 2 are considered public health menu set objectives, and there are 2, and CMS has ruled that you have to do at least one of these 2. One is the ability to submit data on immunization to a registry, or the ability to provide surveillance data, syndromic surveillance data to a public health agency. That would be basically a list that might have 1 or more patients with a particular diagnosis. We could talk about that quite a bit, but we don't have enough time tonight. I want to talk specifically about meaningful use for specialists, because even though there are quite a few core set as well as menu set that meaningful use objectives that are required. An example of a psychiatrist, most psychiatrists probably are not documenting vitals, even though they're eligible providers. Chiropractors typically are not e-prescribing medications, but they're eligible providers. Optometrists probably aren't doing a lot of immunizations. I mentioned earlier, radiologists probably aren't doing a lot of computerized order entry. Urologists probably not doing a lot of immunizations, and pediatricians. Their population may not fall into the population that certain meaningful use objectives match. So what are we going to do? What are these specialists going to do? What are we going to do? Well, as we spoke earlier, there are a number of different ways, both in what can be excluded and what has to be reported, that makes it really not too difficult at all for providers who are specialists to still qualify for the EHR incentives. There's no requirement to document or report any measure objective if they don't do them because they're outside the scope of your practice. Now, in some cases, and we'll look at the details, the government regulations very clearly say what are the requirements to be able to exclude some of these objectives, and we'll take a look at those. Some are excluded, can be excluded, some cannot. And when you actually report to CMS and apply for the incentives, that's when you would test which measures are not relevant to your practice. I want to touch on some specific exclusions here. Exclusions are out of scope. There is a requirement, as we saw, for computerized physician order entry into a certified EHR. However, if the eligible provider writes fewer than 100 prescriptions during the EHR reporting period, they can exclude that. They'll be able to attest that they write fewer than 100 during that reporting period, and they can exclude it and not have to meet that requirement. Now, interestingly enough, that reporting period for the first year, that reporting period can be as short as 90 days. So based on Medicare billing being sufficient to that 9-day period meet the $24,000 in Medicare billing. So that would be under 100 prescriptions possibly during that 9-day period. The next year, to exclude this objective, it would, since it's a total year reporting period, they'd have to exclude this, would have to write fewer than 100 prescriptions during the entire year. So a little easier that first year to do exclusions probably. E-prescribing is also related. The computer physician order entry, part of that is e-prescribing. So in both of these, e-prescribing and CPOE, if you're writing fewer than 100 during the reporting period, those can be excluded. Recording and charting vital signs. If you're seeing only patients 2 years or younger, or if you believe that the vitals, height, weight, and blood pressure have no relevance to scope of practice, you can attest to that and exclude that, and that will not prevent you from getting the incentives whatsoever. The objective for to be able to record smoking status. If you see no patients who are 13 years or older, you can state that, and you will be able to exclude that for stage 1 meaningful use. The requirement to provide electronic copy of health data. If you have no requests from patients during that reportable period for these electronic copy of their health information, you can exclude it. Some physicians, some eligible providers do not really have office visits. They're not seeing, the way they deliver health care does not involve the direct clinical encounter with patients. They don't have office visits. If they don't, then they can exclude clinical summaries. Implement drug formulary checks. This is, as we were saying earlier, the requirement to check a patient's insurance or a preferred drug list to see if particular medications on it. If you write fewer than 100 prescriptions during that EHR reporting period, that can be excluded. Again, some of these exclusions are from the core set, and we hear that the core set's required. It is required, but nonetheless, exclusions are available, strictly by regulation. Lab results. Their requirement to incorporate lab results in a structured format. But if you order no lab results, result in a numeric format during the EHR reporting period, 90 days or perhaps a full year, that's also can be excluded. There's a requirement to send reminders to patients. But if you have no patients 65 or older or 5 years or younger, that's also excludable. Requirement to provide timely patient access to a patient's health data. This is what we mentioned earlier, like something like a patient portal, where a portal could log in and see some of their information. However, if you're not documenting this type of information on a patient, problem list, medication list, lab results, if you're not generating that type of clinical information on the patient, then there's no requirement that you provide that timely patient access to their health data, because you're not generating that health data. Perform medication reconciliation, also that is excludable if you were not the recipient of any transitions of care, a patient who's going through transitions of care. And just stop here for a minute, because you can see there is page after page of exclusions. We're going to talk about every one of them. So the one thing that we need to keep in mind is that for an internist or a general practitioner, there's that requirement to do for stage 1, 15 core set and 5 of 10 of the menu set. That means 20 different meaningful use objectives that they need to meet. A certain strategy has to emerge for them to come up with a proper incentive roadmap to meet that. But on face value, that's 20 objectives that must be met. But for a specialist, depending on the way they deliver health care and the exclusions, instead of 20, this could be considerably less. instead of 20, it could be 12, it could be 10. It'd be much, much lower. The capability to submit electronic data to immunizations. If you don't give any immunizations, then you don't have to meet this requirement. It can be excluded. The capability to submit syndromic surveillance data to public health agencies. Again, this is a certain type of file format that could be submitted to CDC or something like the CDC that would have one or more patients with a particular diagnosis. But if you're not collecting any of that information, this can also be excluded. I want to talk just a couple of minutes here about certified technology. The HITECH Act defines certified technology as qualified electronic health record certified as meeting the related HHS standards. So Health and Human Services created a number of committees that recommended what should be in certified technology, what the certification criteria are. They're started allowing different entities to apply and be authorized to be testing organizations. And these, there's numerous, there's 5 or 6 right now of these ONC authorized testing and certifying bodies have been approved and certification has begun. So you have to be a meaningful user, but the technology you use must be certified by a government authorized testing and certification body. Talk a minute or two here about the actual registration process. Some of you may have already registered. The online registration process began on January 3rd. Requirement is that eligible provider must be enrolled in Medicare, Medicare Advantage or Medicaid. Must be enrolled in the CMS provider enrollment chain ownership system and must have a national provider identifier. Since the incentives are based on a provider-by-provider basis and not on a practice basis, it is a requirement that each registration take place for a particular individual. Interestingly enough, under this program, if a practice had 10 physicians in the practice, 5 of them could elect not to be in the program at all. 3 of them could be in the Medicare program. 2 might qualify for the Medicaid program. So it's really on a provider-by-provider basis that the meaningful use is demonstrated, as well as the incentives are granted. To become a meaningful user, try and make it relatively simple. There's really 4 steps, so there are many steps in between these major ones. You have to obtain certified technology. It must be used in a meaningful way as defined by the government. That's not only the functionality, but the ability to report when applying for the incentives, that you're meeting certain thresholds. An example I will give is there is a meaningful use objective that you give at least patient-specific educational materials. By patient-specific, it could be based on their diagnosis or medications or lab test results for a particular patient, that you provide that type of information for at least 10% of your unique patients during the reportable period. So to document that meaningful use when that occurs online, for 2011 anyway, it would just be attesting that at least 10% of your unique patients received those patient-specific educational resources. So to document that meaningful use and then just and apply for the incentives. CMS has already said that that incentives will be checks essentially will be cut on a monthly basis, rolling basis, and then when you apply, you should get a check within 4 to 6 weeks. Under the Medicaid system, which didn't require meaningful use for the first year, several weeks ago, the first Medicaid eligible providers have already received their checks, and several hospitals have already received checks. So it's starting to flow. One interesting thing I say first here is obtain certified technology and then use in a meaningful way. There is actually very clearly defined clarification from CMS that the technology you're using, the EHR you're using, does not have to actually be certified at the beginning of your reportable period. By that I mean if you are using an EHR that maybe has not gone through the certification process yet, or you have one now, but within that application is the capability to demonstrate and has the functionality for meaningful use, and you start using it in that manner, that as long as the application itself becomes certified by the end of your reporting period, that will still count. Kind of an interesting little detail there. How to maximize the incentives. As I said, the Medicare incentive program started January 1st. Enrollment began January 3rd. To obtain those maximum incentives, we're talking Medicare, you meet the requirements, certified technology, meaningful user, in 2011 or 2012. That's purely for the financial side. The next text there, let me explain that. To obtain the maximum breathing room for transitions, you meet the requirements in 2011. Now, the reason I say that is because there is a requirement that if you, that 2013, you have to be at stage 2. So if you have to be at stage 2 at 2013, if you begin in 2011, get used to the meaningful use workflow and the types of data you're going to have to gather and how you report it in your system and in your practice. You'll do that this year. You get more used to it to 2012, and then in 2013, you're going to have to be using stage 2 certified technology as well as stage 2 meaningful use objectives. So there'll be a jump from after 2 years of stage 1 to then to stage 2. If you wait till the fall of 2012, then you've already given up a lot of time to adjust to your system. And so after maybe just 3 months or 6 months of stage 1, you very quickly then have to go up to stage 2. So you don't quite have the breathing room to incorporate the type of change that's going to be required. But 2011, 2012 for financial, leave no money on the table. Maximum breathing room, you start in 2011. Escalating penalties will occur beginning in 2015 for eligible providers that have not become meaningful users of certified EHR technology. And these penalties are just a percentage reduction in Medicare reimbursement. So the program is voluntary, relatively voluntary. If you don't accept Medicare reimbursement, then you can't be penalized for it whatsoever. Resources. There, speak a minute or so here about resources. Many, many resources out there. I constantly run across misinformation. I think it's well-intentioned, but a lot of misinformation. I think really good sources to look for are from your specialty medical associations. I think the needs of radiologists, the needs of urologists, needs of different groups are very particular, and what they will need to do and their ability to come up with a good strategy to how to meet the meaningful use objectives is, I think that information can frequently come from those medical associations that are specialty specific. I've seen some very, very good information at the different specialty medical associations. One of the sources I have up here is the incentive roadmap. This is really the first meaningful use step-by-step manual for eligible providers. I've tried to find this type of book 6 months ago for some clients I was working for. Couldn't find it, so I wrote it. So that's a book I've written in version 2. It just come out with a chapter on specialists. The Virtual Extension Center is a very, very good resource. That's actually the website that is sponsoring this webinar tonight. And so the information there is to register. It's free for hospitals and eligible providers. Lots and lots of information there will be for the next 5 years. And then last but certainly not least is the official CMS website for the Medicare and Medicaid EHR incentive programs. Lots and lots of information there. Very good frequently asked questions. You can ask a question there, maybe weeks and weeks before you get an answer back, but there are also a lot of very good resources there.
Well, Jim, that
okay.
was terrific.
Okay, thank you, Carol. I'm sorry, it went on a little long, but I wanted to cover everything in detail.
Well, that's okay. We have quite a few questions, and I want to make sure that we get them all in the next 10 minutes.
Okay, thank you very much.
I hope it's okay. Yeah. So I'm going to just plow right in and try to get these questions answered. The first, actually, several attendees asked the same question. Do you need to wait to attest in 2011 until you reach 24K in billable services? So if you don't reach a 24K in the first 90 days, should you wait to attest even if you've been an MU, reporting MU for 90 days?
Right. Well, yeah, let me tell you, I've heard this answer 2 different ways, and I don't know the exact answer. I know I have had some people tell me that it is possible to go ahead and attest that you have been a certified, an INF user of certified technology for 90 consecutive days. And even if you haven't met that $24,000 in billable services, somehow the government is going to track that. And that when you get to that point of $24,000, they'll know you're at the maximum amount to get that $18,000 maximum incentive, and then they will send you the money. I don't know if that's true or not. I have had some people tell me that. But so I don't know exactly if that's true or not.
Okay, all right. Maybe we can look into that. We can respond to that in a post or something. So I guess it makes sense because it's through Medicare and Medicaid payments. So
sure.
Yeah. Speaking of payments, somebody asked, is it true that providers can start receiving payments in May? I've sort of heard that that same time frame as well. That May is when checks start rolling off the printing press.
Sure, exactly, and CMS has been very clear about this, and they have said that they expect the first applications for maximum incentives they're expecting in April, and they have said that the first payments for Medicare can be expected in May. So I think we'll see it, and they've said that publicly a number of places. Yeah,
no, they have. So it must be true.
Yeah. Well, and I'd have many people I've talked to in the last year or so said, this money will never come. But 2 weeks ago, the Medicaid money started coming out. So.
Well, that's true. That's true.
Sure
several of our attendees asked, whether or not, confusion whether the providers are, quote, eligible and what resource they can reference to ascertain a reliable answer. I'm going to answer that. I would say, if you're attending this webinar, then you're a VEC member, and in the VEC resources, there is a webinar, recorded webinar on that particular topic. Who's eligible, why you're eligible, how you're eligible. So I would take a look at that recording. It's in the final rule library in the VEC. So that's the resource that I would use, but then I'm sort of partial to high-tech answers. So next question is, if you participate for 90 days for the incentive the next month, if you participate for 90 days for the incentives, do they go by the allowable amount billable for the previous year, or do they multiply the 3 months you are eligible to find out if you equal the $24,000 and receive the maximum amount? I guess we're getting back to this 24K billable question.
Sure. And that really, that Medicare billable amount is during the reported period of meaningful use.
Got it. Right.
So,
yeah.
Sure.
Attendee asked, do I understand correctly the EP must qualify in year 1? That's a great question.
By qualify, and I don't know if the question is in 2011 or.
Well, that's how I read it. I mean, like, can you qualify after 2011? Can you still qualify? I guess you can, but just not for the full amount.
If you
right.
you can become an eligible provider in 2012 and still
Sure.
get the full amount. And
right.
2012 is still just at a minimum of 90 consecutive days.
You just refer to that the chart that you showed.
That's right.
Right.
That's exactly right. I believe you're going to have this presentation on your website. Is that correct?
We are. We've had a number of people ask that, so yeah.
Okay.
Next question. Is it recommended to register for the incentive program now if we are not participating in calculating our 90 days until October 2011? I think you already answered that as well. Register now. You can register
sure.
now, so you might as well register, right?
That is correct. And the last I saw, the first week or so, somewhere between 1,000 and 2,000 physicians or eligible providers were registering a day. One thing, I got a call from a practice administrator who has about 20 physicians, and they're allowed to register those physicians, but they're having to register them one at a time.
Yeah, which is a lot of work, right? Right.
Yeah.
And we provide in the VEC, on the homepage of the VEC, you will see the logo to link through that you can go ahead and register. It's
sure.
It's below the library wings. You'll see it right there, and you can. There's no downside for registering, right?
That's exactly right.
If I write less than 100 RXs during the reporting period, then I'm not obliged to report this in order to demonstrate MU. But do I have to select an EMR that allows CPOE and e-prescribing even if I never use these functions?
That is a great question. Yeah, and this is something, and this is true for hospitals as well as for eligible providers. And 6 months ago, this was up in the air a little bit, but now it is very, very clear. I work with a lot of, as I said, EHR vendors who are developing this functionality, and so the hope was that for those specialties that were definitely going to exclude particular meaningful use objectives, they wouldn't even have to get those modules certified.
Yeah, right.
Right. However, CMS has really ruled that, and I'm going to read a quote from them. Please note that eligible providers must have complete certified EHR technology or a complete set of certified modules capable of supporting all core and menu set objectives, including any objectives for which the EP can claim an exclusion and menu set objectives that the EP does not select. So you have to have certified technology that covers every one of the modules, even if it's outside your scope and even if you can exclude it. They're really clear about that.
Just in case, right?
Yeah.
Next question.
Which wasn't true, but it is, yeah.
No, it is true. Right.
Yep.
Next question. In determining eligibility, how does one look at radiation oncologists or similar clinicians? Ours are privately employed, work in a facility where the technology is available, but don't fit the traditional model in a PCP setting? Well,
I think I understand the question. Certainly, I've spoken with many radiologists, and the problem radiologists frequently have is if they do over 90% of their work in a hospital, and their place of service is, correct me if I'm wrong, Carol, but I believe the place of service for more than 90% of their Medicare billables are 21 or 23, they are not eligible under any circumstances whatsoever.
Yeah, the thing that Kenny went on to say, maybe the question is who defines the scope of practice. I'm going to refer that attendee back to the recordings that exist already in our VAC membership that talk about that.
Okay.
And actually, where it talks about, effective recording that you did, step one, determine this. If the answer is yes, go to step two. If the answer is no, stop. You know what I mean?
Sure.
So yeah, I think that question, as far as who defines the scope of the practice and who's eligible, is addressed in a number of recordings already existing in the VEC membership, and you find them under the final rule library. Right.
Sure. And let me, I know we're about time, but I see a question there from somebody, and let me just answer this. The question is, as a specialist, could you feasibly exclude most of the core menus items and still get credit? Is there a minimum? It is true. You could feasibly exclude most of the core and menu items. Now, there is a minimum because some menu and course objectives cannot be excluded. However, we have 25 meaningful use objectives, and I believe either 14 or 15, if memory serves me well, can be excluded. So it is possible that a relatively small set of meaningful use objectives can get you the full incentives. Now, one objective that cannot be excluded is the ability to report clinical quality measures. You've got to report clinical quality measures. However, for these clinical quality measures, give an example. All patients over the age of 50, do they get a flu shot? That's a alternative core. But if you don't see patients over the age of 50 and you don't get flu shots or some combination, you're going to get zeros for numerator, denominator, and for the percentage. And it's totally okay that on the quality measures you report, if it's outside your scope and outside your population, to report zeros. So quality measures have to be reported, but it is totally legitimate to report zeros for those quality measures. So
if we've got 5 minutes, I got a couple more really good questions.
Okay, great.
One is, this is a great question. What if the criteria changes in stage 2, so which which will happen, so that I no longer qualify after purchasing an EMR?
After purchasing an EMR?
Yeah.
Yeah. So and so this would be
certification question, really.
Right, it is certification, and so this would be maybe a vendor who went through stage 1 meaningful use certification, and you've got the incentives for a couple of years. It comes time for stage 2, and they cannot achieve stage 2 certification. Then you or something else happens. In that case, you've got to have stage 2 certified technology. So you either, if the company just says, we're not going to do it, maybe we want to go through certification, you can still do what's known through the certification bodies as site certification. If the functionality is there to support stage 2 meaningful use for a relatively small amount of money, you can get that technology certified yourself. If the legacy system doesn't want to do it. But if it's just somebody who, vendors no longer support their EHR and it's not going to be updated with meaningful use objectives, you really have no choice if you want to stay in the program but to move to some vendor that is supplying that stage 2 certified technology. That's a good question. Hope that doesn't happen to anybody.
Well, in the LNC, they've actually come out and, basically already sort of giving a heads up on stage 2, what they're looking at. They've come out. You can publicly comment. They're supposed to have actually published their paper in the Federal Registry today with a 45-day comment period. The idea being, of course, that they want to give these EHR vendors, like a heads up. We're gonna move CPOE from 30% to 60% in stage 2. So be prepared.
Sure.
And that's one of our questions. The CPO requirement asks for 30% or all unique patients to have at least one medication in their list to be entered by CPOE. What if you don't manage the medications in the patient's list?
Well, you mean you're talking about for stage 2?
I think he mentions the 30%, so I'm thinking he's even thinking stage 1 because it's 30% in stage 1.
Sure. Well, I'm sorry. What was the objective? Was it medication list?
Yeah, exactly. What if you don't manage the medications in the patient's list?
Right, exactly. And so let's see. I'm trying to think if active meds is excludable. So in other words, you would have an EHR, but you're not tracking the patient's meds in there.
Right.
You don't have patient meds in there. Well, there is no requirement to manage somebody's meds. The only requirement is that in the EHR, there is an active medication section, and it either has meds in there or it has some structured data that says patient is on no meds. So that 30% requirement is just checking to see that there is something there. And so from the standpoint of incentives, they want to make sure that something is being put in
right,
there.
Right.
So,
30% is the minimum, and then that'll move to what they're suggesting is, what they're recommending rather, is it'll move to 60% in stage 2. Yeah.
Yes. We'll see. It'd be the end of this year before they really give us the details on that.
Sure.
So, yeah.
Kind of a little bit off the beaten path question, but do we meet a public health menu objective if we could submit data electronically, but our state, which happens to be Wisconsin, not to call Wisconsin out, is not ready to accept an electronic submission?
You know, that is a great question. For both the immunization registries and the public health surveillance, the only requirement for stage 1 is that the provider, not even the provider, but the practice of the provider, tests that capability one time, and it doesn't even have to be with real patient data. So there is, you can choose those, you can choose one of those or both of those as a meaningful use objective you're going to meet. And to meet it, all you have to do is a test that has been tested one time during the reportable period.
Well, there you go.
So
on a side note, go Green Bay. Next question. How will patient volume be validated for Medicare versus Medicaid incentives?
Let's see, for to become eligible for the percentage thresholds to be eligible for Medicaid. Is that the question?
Yeah, how the patient. I guess the question is, the attendee's asking, how is it validated? You know, for Medicare versus Medicaid incentive. Like, how, if you're making the choice, you know what I mean? If they're in office and they've got to decide between Medicare and Medicaid. Sure. How is it validated?
Well, you know, it is a percentage. It is 30%, and there's it's 20% Medicaid threshold for pediatricians, 30% for all other providers, and there are a couple of different ways that you can validate that percentage, whether it's a percent of patients or there's several ways to do that, and it's a little bit complicated. If that person could send in, I'll be glad. I'm trying to think how I could send. I've got some really good documentation on that. Well, if they think they're eligible for Medicaid, because if you are eligible for Medicaid, that's definitely the way that you want to go.
Yeah,
so I'd like to provide that.
Yeah, and there are webinar recordings in the final rule library of our wing and the VAC that actually talk about specific thresholds, like answer yes, answer no, and so I'm going to refer the attendee to that. You know, check out those webinar recordings on which incentive. In fact, there's one specifically about which CMS incentive program to pick, Medicare or Medicaid, and I think that'll help answer that question.
Okay. Great.
I've got two more. We'll take 2 more questions. This is a good question too. Will the software have to be able to do the basic requirements, even if the specialist doesn't? For example, immunizations for optometrists. Optometrists don't do immunization, right?
I'm sorry, ask that again, please.
Jesus report 0. You know, the basic of the question is asking, does the software, you know, has to meet all these requirements? Does it still have to meet them, even if the specialist doesn't fulfill that?
That is an excellent question, and yes, it is. So I've been through numerous of these certification tests, and during the test for the quality measures, a certified EHR module or complete EHR that does quality measures has to demonstrate to the tester a minimum of 9 quality measures, and they have to have enough data in patient records so that real numbers are being generated there. The end users may never have those kind of patients, but then the testers require during the test for the vendor to go in and do all kinds of different clinical documentations on practice patients, and then come back out and show that those quality measures are correctly being recorded on the front end.
Right.
So yeah, there is a requirement that it actually works.
Got it. A few more questions related to, basic, requirements and eligibility and which program to pick. Again, I recommend that for those attending to those questions that you go to the final rules library of our wing and look at, the CMS incentive recording that we did. And if you have questions, you can email a question through our Ask Our Experts forum. I'll take one last question, and it is, let's see here. The incorporate clinical data, let me go back.
Lab.
Incorporate the clinical lab test data as structured data. A document that I got off the CMS website stated that a scanned document meets the criteria. My concern is you mentioned it needs to be searchable. The practice does not do any labs in the office. All are done outside of the practice. Scanned documents are not necessarily searchable. Could you expand on this requirement?
Sure. The reason I say you really want it to be structured data is because there are a number of other meaningful use objectives that are based on structured lab results. I'll give you just one example. The requirement to generate patient list based on demographics, problem list, medications, and lab test results. And so there is a requirement for the certified technology to generate a list of, I'll give you an example, of patients who have an LDL over 100.
Got it.
If that's not structured data, we wouldn't be able to get that list. Now, incorporate lab data for stage 1 is in the menu set, so you can defer that one. If you choose to, and not even count it as an exception that's outside your scope or anything like that, is the one that can be deferred, 5 out of 10 that can be deferred. But there are a number of places that you really are going to need that structured lab data to generate those reports.
Great. Well, Jim, thank you so much for your time. It's been terrific. For those of you whose question we did not get to, please visit the VAC, log into HiTech Answers with your username and password. Really look at the recordings in the final rules wing, because that's where some of these questions are really going to be addressed. And if you still have a question, of course you can complete a form, send us an email to ask our expert, and we will get back to you. Thanks again, everybody, and we'll see you at the next VAC event.